Today's recording for Pathophysiology 2 covers the topic shock. We can generally define shock as being a life-threatening condition, and it occurs when the circulatory system fails. It's failing to perfuse the cells, the tissue, the organ. Remember that cells make up tissue and then tissues come together to make up organs. So it's failing to perfuse these cells adequately. And this results in really a widespread impairment of cellular metabolism, which is a requirement for survival, as well as tissue function. So when I say the word perfusion when it comes to our cells and our tissues, what do I mean by that? Well, it's defined as being the adequate amount of blood flowing through the small vessels. And we need an adequate amount of blood flowing through the small vessels in order to maintain tissue function. So at what point would we see inadequate tissue perfusion? When would this occur? Well, really anytime there is a reduction in the delivery of blood, oxygen, and nutrients to cells and tissues. So this can occur from a variety of reasons if there's some sort of dysfunction of the heart or other systems. If there's a reduction in overall blood volume, we know that volume is directly related to blood pressure, and we have to have a sufficient amount of blood pressure in order to properly perfuse tissues. Maybe other areas are functioning properly, but the microcirculation is failing. And so when I say microcirculation, I'm referring to the circulation of blood in the smallest blood vessels. So the capillaries we know are the smallest blood vessels that are at the level of the tissue. And they are really the means by which blood will be able to perfuse the tissue that these capillary beds are associated with. So that described the causes of shock. And this is also speaking very generally because I'm not speaking specifically to heart disorders or other system disorders. I'm not talking about the reason why the blood volume has dropped. So this is speaking generally. But the consequences are going to be the biggest problem. So shock will trigger this cascade of events that can further damage tissue, and it does this via these positive feedback loops. Remember that we have negative feedback loops in particular that work to keep us within a very narrow range, maintaining homeostasis within our body. And what shock does is it puts us further and further and further away from homeostasis, and that's not beneficial. There's no beneficial end to this loop. Shock will lead to general, really widespread loss of cellular metabolism because the cells are not receiving what they need to undergo normal metabolic processes. And we know tissue perfusion will fail, and this means that the cells are not getting many different things, including oxygen. So we call that, as we know, hypoxia. And then somebody experiencing shock can also experience multi-organ failure. And we'll talk about this later today pertaining to the acronym MODS, but this is a progressive state and it involves the failure of two or more organ systems in the body. So we can say that shock then is a multi-systemic syndrome, and it involves, as we know, failure of the cardiovascular system, but specifically of the microcirculation, and so the cardiovascular system is failing to perfuse tissues adequately. And it's going to be vital then to open up those capillary beds that have collapsed or are not allowing for proper perfusion to occur in order to prevent progression. And as already mentioned, shock can trigger this cascade of events that can lead to more damage where we move further and further and further away, referring to a positive feedback loop, moving far from homeostasis. And it can result in multi-organ failure, as already mentioned, so we'll come back to this. I know this is a black and white image, but you can see in the skin the irregular areas of tissue perfusion, so it gives this blotchy appearance, and this can be an indication of shock. Remember that the functional unit of the kidney is the nephron, and there's like 1 million nephrons within the kidney, and it is the nephrons, so this whole tubular system that is both a tubular system and lots of blood vessels as well, they can be prone to damage when somebody experiences shock, and it needs to be corrected quickly because we need to be able to make sure that the kidneys are filtering, because they are a filtering system, filtering out what needs to be filtered out. So getting rid of excess fluid and solutes, or holding on to fluid and solutes if that's what we need. And of course, the tubules, when they produce urine, are also going to be getting rid of any toxins that should not remain within our blood. And so if the microcirculation at the level of the nephron is affected, you can see why that would be an issue. So it needs to be corrected fast. This slide came up in Altered Phys 1 during the Altered Cell and Tissue Biology lecture. Remember, this is the normal appearance of a cell versus the effects of shock. And so we're going to look for just a moment, and this is summarized a bit on the next slide too, what are some of the effects that we'll see from shock compared to normal. So cellular edema, that you can see right away. You can see that the cell is larger, and it's larger because there is excess fluid within the cell that causes it to swell. Why does this happen? Well, this is shown on the next slide, but you'll be reminded of the fact that if a cell is not getting enough oxygen or other substances for normal metabolic processes, then the cell mitochondria won't produce ATP. And we know that ATP, that stored energy, is required for the proper use of transport mechanisms. The transport mechanisms, remember, that are built into the cell membrane that would allow for controlled movement of substances into and out of the cell. So if we don't have the energy to control this, then it becomes uncontrolled. And we have this uncontrolled movement of ions and fluids into and out of the cell. We can see that if it distends like this, the membranes are more permeable. And so you can see that it's ruptured here and it's allowing substances that shouldn't leave to leave. In particular, remember lysosomes that are found within the cell, those sort of vacuum cleaners that go around and clean up substances that shouldn't be there by using these powerful digestive enzymes that they possess within them. And if the membranes of the lysosomes become disrupted because of cellular damage, then it can damage inside the cell. These enzymes are very, very potent. They're not meant to be just floating around the cell. But if the actual cell membrane itself is disrupted, then we can get the release of substances such as those powerful digestive enzymes, which can affect the tissue in the area in between cells, but also other cells. What really does contribute to that cellular swelling, though, is that influx of sodium. And sodium influxes into the cell because we've lost the control that we would normally have with ATP of keeping only a certain amount of sodium inside the cell. And so if sodium floods into the cell, we know because of osmosis that water wants to follow. And so that's what really contributes to the cellular swelling. You can also see, compared to normal, that the mitochondria have become damaged. Even the cisternae here of other organelles is becoming distended. And then the other piece of information to mention to you is the efflux of potassium. Potassium leaving the cell, again, because of loss of that proper functioning sodium-potassium pump due to not enough ATP. When potassium leaves the cell, it can go into the blood and lead to a state of hyperkalemia, so a high level of, this is representing potassium in the blood. And hyperkalemia is dangerous because it can affect how muscles function, including the heart. So this summarizes a bit of what I already spoke about, showing you just the right side of that cell that is affected by shock. Let's say somebody is experiencing hypoxia and the cells in their body are not getting enough oxygen. We know that when cells receive oxygen and glucose, they're going to make the most ATP, thinking back to the different forms of cell metabolism, where you would have learned about the about glycolysis, which doesn't require oxygen but doesn't make a whole lot of ATP. And then we have the citric acid cycle or the Krebs cycle and the electron transport chain. These are going to utilize oxygen to make the most amount of ATP. And we use ATP so much that we need oxygen so that we make as much as we need. So if a cell is not getting enough oxygen and not able to undergo the normal aerobic, referring to oxygen, aerobic metabolism, so if it's not getting enough or for some reason it can't use it, then the cell is going to shift from this aerobic state to anaerobic metabolism. So this is metabolism not involving oxygen. And so as I already told you, this means less ATP is going to be produced per molecule of glucose, which is stated here. And we know ATP is needed for many different functions, including one example already discussed is the sodium-potassium pump, which means that sodium is going to accumulate in the cell, as shown here, and water is going to follow. Potassium is going to accumulate outside of the cell and could potentially lead to hyperkalemia. With that sodium moving into the cell, it's going to cause water to follow because of osmosis, causing the cell to swell. When the cell swells, it's almost like filling up a balloon with too much water. Eventually, the membranes are going to stretch out, become damaged, become damaged, and become disrupted. So disruption of the cellular membranes and of the cellular membranes within the cell, the actual membranes of organelles can be disrupted as well, where we end up with the release of contents within structures such as the lysosomes. And those can damage inside the cell and outside the cell. And even if an organelle doesn't rupture, you can still see the swelling that's occurred, and that is going to prevent that organelle from functioning properly. Now, with all the different substances that are now able to leave the cell and be kind of in the interstitial area, which is in between cells, the fluid that's in the blood vessels is going to want to leave the vessels to go and dilute everything that's present within the interstitium. So now we have a reduction in the amount of blood volume within the blood vessels. And if we have less volume, we have less pressure. So this leads to a state of hypotension, leading to inadequate tissue perfusion because there's not enough volume and pressure to perfuse the tissues, leading to shock. Still looking at the cellular alterations that are evident with shock. While this is a very busy diagram, some of what I'm going to discuss is just a review from what we just went through. So a major problem that we know is going to occur in these situations is there's some sort of impairment in oxygen delivery or oxygen use, leading to a state of anaerobic metabolism. Anaerobic metabolism means less ATP is going to be produced. Less ATP means that the sodium-potassium pump is not going to function properly. This is going to allow sodium to infiltrate the cell and water will follow, leading to cellular swelling. We talked about how eventually there will be a reduction in circulatory volume as blood from the vessels leaves and goes into the area of the interstitium and maybe even into the cell. In any case, it's leaving the vessels. This reduction in circulatory volume will mean that tissues cannot be perfused properly. A reduction in circulatory volume can also signal the clotting cascade, and this contributes or is a component of that positive feedback loop that we spoke about. We know as well that when there's that increase in sodium and water within the cell, it's going to cause the cell to swell, and one of the events, not the only event that we'll see, is a release of lysosomal enzymes, which are very damaging. Another event or outcome that's seen with anaerobic metabolism is the production of lactate or lactic acid. And lactic acid, when it builds up, if it builds up too much, like it would in this situation, it can lead to metabolic acidosis. And metabolic acidosis can also cause disruption of many different systems in the body, but one thing that it can contribute to is a reduction in oxygen affinity for hemoglobin. So any oxygen that we would normally be able to have on hemoglobin is now lost, further affecting the delivery of oxygen to tissues. Next up is impairment in glucose delivery and use. If the cells cannot get the glucose that they need in order to produce ATP, then the body goes into stress mode. And what we'll see with this is glucose concentration will increase in the blood. And this is because of cortisol. We're also going to see this because of catecholamines involved in the sympathetic response and because of growth hormone. All of this is going to contribute to an increase in the amount of glucose in the blood. One, through gluconeogenesis, which is the formation of new glucose, and glycogenolysis, which is the breakdown of glycogen in order to release glucose. It will also cause a breakdown in fat, so lipolysis, which will put more fatty substances into the blood, triglycerides, free fatty acids, in order to utilize this instead of glucose for energy. And so really the body's reacting to the situation by trying to get energy from anywhere and everywhere as a response to this stress, but this is going to deplete stores. That's all you need to know from this slide. And now that you know the common denominators that are involved in shock, really regardless of cause, now I'm going to go into the different types of shock that exist. The different types include cardiogenic, hypovolemic, neurogenic, anaphylactic, and septic. This slide is a really introduction overview that you can come back to during your studying once you've learned about each one specifically. First up is cardiogenic shock. This type of shock results from the inability of the heart to pump adequate blood to tissue. The heart's not functioning well. It's really a state of inadequate systemic tissue perfusion, with the most common causes listed here: myocardial infarction or heart attack, left heart failure, ventricular dysrhythmias, where the ventricle, which we know is so important, has an abnormal rhythm, not being able to pump blood out properly. And then cardiac tamponades. We've talked about all of these throughout this course so far. In any case, whatever the cause is, we know the heart is not functioning well. And as cardiac output decreases, we're going to see these initial compensation mechanisms occurring. So these adaptive responses that are activated. And this includes, for example, the renin-angiotensin-aldosterone system and antidiuretic hormone. These two we know are involved in fluid retention, encouraging more fluid to remain within the blood vessels. More fluid is more volume, it's more pressure. This is the body trying to compensate for tissues not getting enough oxygen. Another event that we'll be seeing is activation of the sympathetic nervous system, which involves catecholamine releases such as epinephrine and norepinephrine from the adrenal glands. And the effect that this is going to have is vasoconstriction. Vasoconstriction is going to lead to an increase in vascular resistance. So this is where we get into kind of the limited short-term effects of this compensation. So an increase in vascular resistance with the design to increase blood pressure. There's going to be an increase in heart rate, an increase in contractility. And so this compensation mechanism initially, especially in cases of mild shock, is going to be able to maintain some contractility and heart rate and blood pressure. But it's short term, because it's not going to take long before this already poorly functioning heart is going to suffer from the increased workload. And this increased workload of the myocardial cells means obviously that they're working harder, but they require more oxygen themselves. And so what we see overall with this increase in myocardial workload and the increased demand of oxygen of the myocardial cells is that they're not going to be able to get enough oxygen. We can't meet those demands. Again, the heart is functioning poorly to begin with. And so we're going to end up in a state of ischemia to the heart muscle, leading to hypoxia, further worsening the initial problem. Now, for the most part, reiterating what I spoke about on the last slide, when there is some sort of heart problem with cardiogenic shock, where there is a reduction in cardiac output, so the amount of blood that's pumped out into the systemic circulation, we know already that there's going to be compensatory mechanisms in place, including the RAAS system, renin-angiotensin-aldosterone system, and ADH, which will have the effect of increasing fluid retention, which means that more volume of fluid will be within our blood vessels. We know also that there's going to be the release of catecholamines, epinephrine, norepinephrine from the adrenal gland. This is going to cause an increase in vascular resistance, as already discussed, but we can more specifically call it systemic vascular resistance because it's resistance within the vessels, within the systemic circulation. Now, these changes, these compensatory changes, are going to have an effect on the amount of blood that's pumped out of the heart. So naturally, we'll see an increase in preload, so the volume in the ventricles at the end of the filling phase or diastole. We're going to see an increase in stroke volume, the volume that's actually pumped out, as well as an increase in heart rate. And so people that are suffering from this will have such an increase in heart rate that it would be classified as tachycardia. Now, these are the compensatory mechanisms, and these will initially be able to compensate for the initial problem with cardiac output, but not for long. Not for long for a couple of main reasons. One is that we know, for example, with an increase in preload, that as the heart starts to fail because it's been loaded far too much, it can lead to systemic and pulmonary edema. So this goes back to our heart failure lecture. So swelling within the systemic and the pulmonary regions of the body. And if the pulmonary area is affected, it can lead to shortness of breath. So really the blood's just backing up into where it's not supposed to be. But what we talked about on the last slide was that these compensatory mechanisms, all good initially, mean that the heart cells have to work that much harder. Those myocardial cells, which make up the myocardium or the muscle of the heart, they have to work that much harder. And when they work harder, they need more oxygen. But the problem is the heart is already failing to begin with to do what it needs to, what it's supposed to do. So this increase in demand is not going to be able to be met, again, because there was a problem already to begin with. And so the cells are going to start to fail to do what they need to do. So now we get the opposite happening. We have a reduction in cardiac output, remembering that that includes your stroke volume and your heart rate. Where it's going to be a reduction in ejection fraction, the amount of blood that's actually pumped out, expressed as a fraction with each contraction. Less blood being pumped out of the heart, less volume of blood being pumped out of the heart into the systemic circulation means that there's going to be a reduction in blood pressure because we know volume and pressure are directly related. And the combination of a reduced blood volume out of the heart as well as a reduction in blood pressure, both of these variables are going to mean that tissues are not going to be able to be perfused properly. One, there's not enough blood being pumped out to perfuse tissues, but there's also not enough pressure to take the blood that is there to perfuse the tissues. Reduction in blood flow, we know, leads to hypoxia. We know hypoxia impairs cellular metabolism, and then the myocardial cells become entirely dysfunctional. So really remembering that it's all cells in the body that end up being affected by this. So this myocardial dysfunction means that all cells throughout the body, in the case of cardiogenic shock, are not getting the blood supply that they need for survival. The next type of shock is hypovolemic shock. Hypo refers to low, volemic refers to volume. And so when I say volume here, I'm talking about intravascular volume, so the volume of blood within the blood vessels. So we can really just summarize this to say that hypovolemic means low volume in the blood vessels. There are a few different causes, including hemorrhaging. So this is where somebody is bleeding out, and that would make sense that if you're bleeding out of your blood vessels, then you're losing volume within the blood vessels. Burns and diarrhea involve a reduction in fluids or loss of fluids, and we know fluids are a huge component of overall blood volume. This state of hypovolemic shock can occur with as little as 15% loss of volume within the blood vessels. So what that means is that it can happen very easily. And so to prevent hypovolemic shock, one of the medical interventions would include fluid replacement in order to maybe prevent shock, but also as part of treatment. So for some reason, if somebody is suffering from a reduction in intravascular volume, we know that that means there's going to be a reduction in cardiac output. If there's less blood within the vessels, less is going to be pumped out. The initial response, compensatory, is going to be a catecholamine release, epinephrine, norepinephrine, which is going to have the same effects that we talked about already, with an increase in heart rate and contractility and an increase in systemic vascular resistance. And the end result of this increase in systemic vascular resistance ends up leading to a reduction in cardiac output as described on the last slide. Other compensatory mechanisms include a shift of interstitial fluid. So fluid that is found interstitially, that is in between cells, is going to migrate into the blood vessels to increase the volume intravascularly. Aldosterone and ADH will also be involved. Again, fluid retention to increase intravascular volume. Splenic discharge. The liver and the spleen, so splenic refers to spleen, but the liver and the spleen are going to add to the blood volume by releasing stored red blood cells and plasma. And all of this has the effect then in increasing overall volume. So we have an increase in volume and an increase in heart rate and contractility, leading to really the same effects that we saw on the previous slide. The body's tried to compensate and has failed. You can make note on this slide if you'd like that this is still referring to hypovolemic shock, and it talks about pretty much everything that I've already spoken to. It just shows it in a different way, so it might be valuable for studying. But this is a more specific example where somebody is hemorrhaging, so they're bleeding, loss of blood. We know we have those compensatory mechanisms that exist to try to reverse the effects that hemorrhaging would have. So for example, in order to maintain cardiovascular function, the heart is going to increase its rate of contraction and degree of contractility. We also know we're going to see vasoconstriction. Where do we see vasoconstriction? Well, it's going to be in areas such as the skin and non-vital organs. And this vasoconstriction will increase blood pressure because if you think about it, if you have a long flexible tube and water is flowing through this tube, and at the end of the tube you tie it off or you squeeze it with your hand, that's going to mean that if less fluid's moving through that tube, then it's going to back up, and when it backs up, that's increasing pressure. And the reason we can vasoconstrict in non-vital organs and the skin is to really divert the blood to vital organs. Another compensatory mechanism in order to maintain blood volume is going to be activation of the renin-angiotensin system, as well as ADH. There's also going to be stimulation at the level of the hypothalamus in order to encourage you to drink. But if somebody is in a serious state, they may not drink, and so fluid replacement would be done medically. And then I spoke about how the liver as well as the spleen are going to release stored red blood cells and plasma found within it. So just a slightly different way to show and demonstrate the same thing that I already discussed. Next up is neurogenic shock. Neurogenic shock is caused by alterations relating to the central nervous system. Remember, that's the brain and the spinal cord. And it's mostly due to these imbalances that exist within, remember, the autonomic nervous system that involves the sympathetic and parasympathetic nervous system. So this here you could make a note if you wanted to, just for your own understanding, that we have this imbalance in the autonomic nervous system, specifically pertaining to the sympathetic and the parasympathetic nervous system. And the result is going to be massive vasodilation that is experienced all throughout the body. So the vessels dilate. And so the vessels have lost their tone. Remember, they are made up of a smooth muscle that allows them to dilate and constrict in order to properly move blood throughout our body and maintain tissue perfusion and maintain blood pressure, but this is lost. And so a loss of vascular tone means that there is going to be a loss of systemic vascular resistance. That is the resistance within the vessels that the blood has as it moves through. And so the pressure within the vessels is inadequate to drive oxygen and nutrients across the capillary membranes. So that would be reduction in the ability to perfuse the tissues because there's not enough tone and vascular resistance, which contributes to blood pressure. So really, there's enough blood in the vessels. It's just so dilated that it's not moving the way that it should. Naturally, it might make sense that cardiac output is going to be affected because you can think of it like we have all this blood within our systemic circulation that isn't moving at the speed that it should to return to the heart because everything is so dilated throughout the systemic circulation. And so if less blood returns to the heart, then we have inadequate cardiac output. But in any case, we're going to have tissue perfusion reduction, as already mentioned, leading to impaired cellular metabolism all throughout the body. The most common causes include somebody that has a spinal cord injury, or if they have an injury to their brain stem, which is often due to a stroke, but it can be other causes as well. Next up is anaphylactic shock. I feel pretty confident that you've heard of this before, somebody experiencing anaphylaxis. And we talked about this a little bit in the context of allergies in Altered Physiology 1, where we related it to a type 1 hypersensitivity. Anaphylactic shock is an extreme, oftentimes life-threatening allergic reaction to some sort of antigen to which the body has become hypersensitive to. And so even a minor exposure can trigger this massive systemic response that can lead to death. Now, similar to what I spoke about on the last slide, anaphylactic shock can also involve massive vasodilation, which I'll speak to in a moment when we get to this flowchart. Common causes, of course, this is not an exhaustive list. There are so many different potential causes, but bee stings and peanuts are very common, latex allergies as well. So what's happening? Well, somebody's exposed to an antigen, something that other people won't be affected by. And so in the affected people, it would be called an allergen. An abnormal immune response occurs that leads to the release of many different mediators that are going to contribute to the problematic events that occur with anaphylaxis. So the complement system will be activated, remembering that from Altered Phys 1, histamine, kinins, prostaglandins all have a great negative effect because of the quantity that they're released in. So what we're going to see? We're going to see increased capillary permeability. That means the capillaries, the microvascular circulation is going to become more permeable. And that means that blood is able to leave the vessels much more easily and at a rate that's much faster than is considered normal. And so this causes there to be an increase in the amount of fluid outside of the vessels. And if it's leaving the vessels, it causes edema throughout the body. It also means that if fluid is leaving the vessels, then there's going to be less volume within the vessels, leading to a reduction in cardiac output, reduction in tissue perfusion, and impaired cellular metabolism. These similar themes that continue to come up. Another effect from these mediators is peripheral vasodilation. So this is that massive vasodilation that I spoke of, leading to a reduction in systemic vascular resistance and so on and so forth. So this goes right back to the last slide on neurogenic shock. Finally, these mediators also contribute to constriction of smooth muscle that lines other organs that are not related directly to the vessels, because we already spoke about the vessels here. So this is extravascular, outside of the vessels. And so, for example, the bronchus and bronchioles can constrict, making airflow either difficult or impossible. The larynx, so that is the voice box, but this is still the area that air would move past, can spasm, making breathing either difficult or non-existent, and severe gastrointestinal cramps can occur. And so how is this fixed? Well, that's the reason people that have these severe allergies carry an EpiPen, is because the epinephrine found within an EpiPen can be what causes reversal of these effects, allowing the person's heart rate to resume and at a normal pace, and a reduction in swelling in different areas. You can imagine that swelling throughout the neck region, where you're dependent on air coming through, is going to be a problem. And so an EpiPen will help reverse that. So EpiPens can be life-saving. So remember, this is not an exhaustive list. When I say bee stings, I mean really just venom from different insects that can cause a reaction. Another one not shown here would be allergy to certain drugs, like penicillin, for example. And so it's helpful, obviously, to know if somebody has an allergy, because then they can carry an EpiPen with them and maybe wear a medical bracelet. I have my eldest son is anaphylactic to all legumes. And if you look up what legumes are, it's like the largest umbrella of different food items you could imagine. So we have to be very careful, and he has to have a medical bracelet and an EpiPen. Another common allergy is contrast dye. So if you ever have to have some sort of imaging done, for whatever reason, they can inject a contrast dye to make the imaging more clear so you can see more and diagnose better. I have an allergy to contrast dye, so that has to be taken into account if I ever have to have contrast imaging done. The final type of shock that we're going to speak about is called septic shock. Septic shock is a potentially fatal medical condition that occurs when sepsis, which is organ injury or damage in response to infection, leads to very dangerously low blood pressure. And then, of course, abnormalities in cellular metabolism as well. So I told you it's caused by infection, by a microorganism. Now, the most common to make note of would be a bacteria, more specifically a gram-negative bacteria. Now, I'm going to go through the difference between gram-negative and gram-positive bacteria. Maybe you've learned this already, but as a reminder in that case, a gram-negative bacteria will differ from a gram-positive bacteria in that gram-negative bacteria have walls that contain lipopolysaccharides. These are considered endotoxins, the lipopolysaccharide. And when the bacteria gets broken down, it releases these endotoxins. And these endotoxins can enter the bloodstream and travel to tissues where it can activate macrophages everywhere. In addition to that, many cytokines and other factors are released that can lead to a condition or a state called SIRS, Systemic Inflammation Response Syndrome. So this would be a valuable area to star. SIRS, the Systemic Inflammation Response Syndrome, includes fever, tachycardia, so fast heart rate, tachypnea, fast breathing rate, and leukocytosis, which is the production of white blood cells above and beyond what is normal. These clinical manifestations plus bacteria in the blood leads to a state of sepsis. So cardiovascular issues will ensue. You can see the vasodilation and hypotension, that dangerously low blood pressure. And there's really two phases of shock, not just septic shock, but shock in general. We have a warm shock and a cold shock phase. You can see the warm shock occurring first. The warm shock occurs early on, and this is the compensatory component that we've talked quite a bit about. The second is cold shock, which occurs later, and this is where we have really decompensation and where we really see this reduction in cardiac output because the myocardium cannot pump out blood in normal amounts. Now, this event can lead to multiple organ dysfunction, and we're going to be covering that on an upcoming slide. But what I wanted to mention to you is that even though it's stated specifically on this slide that septic shock can lead to multiple organ dysfunction, other types of shock and other injuries can also lead to multiple organ dysfunction, but we'll come back to that. The final thing to mention on this slide has to do with the common causes of septic shock. Again, not an exhaustive list, just giving you some ideas. Pneumonia, wounds, and vascular catheters can cause bacteria to enter the blood, and if it's not controlled, it can lead to septic shock. Bacteria can have this ability to disrupt endothelial function and get into the blood, leading to bacteremia. And the problem with that is once the bacteria enters the bloodstream, it can travel to virtually all cells within the body. Okay, that's the end of our discussion specifically on the different types of shock, but still really on the same topic, we're going to look at disseminated intravascular coagulation, or DIC, and then we'll finish up with the multiple organ dysfunction syndrome that I introduced earlier. DIC is a complex acquired disorder that is primarily initiated by the damage to endothelial tissue, so the blood vessel lining. Really meaning that this state of DIC is caused by some other condition that damages the endothelium. This condition involves widespread clotting and hemorrhaging, as we'll see, and that's because there's an altered state involving thrombin, fibrin, and fibrinolysis, which are all part of the clotting cascade or coagulation cascade. Clinical manifestations include bleeding from venipuncture sites where you shouldn't, bleeding from arterial lines, which is where small blood vessels are leaking blood underneath the skin. Petechia are these pinpoint round spots that can appear on the skin, and they are caused by bleeding as well. And the development of hematomas, which are really large blood clots that can resemble a tumor based on their size. Symmetric cyanosis of the fingers and toes, so that's the turning of blue on both sides. And so the treatment of DIC is going to be removing the inciting stimulus or fixing the condition that's causing it. Okay, so a little bit more still on this topic. The stimulus, whatever the condition may be that is going to lead to DIC, is going to cause this unregulated activation of thrombin. So thrombin is the factor that causes the formation of fibrin, which creates that mesh, if you remember. So we have thrombin forming fibrin. But what's interesting is this isn't just happening locally in one area. This is happening everywhere throughout the body. So it's happening everywhere, it's not remaining localized. So in other words, clot formation all throughout the body. Now, normally what we have in our body are these substances called antithrombins. And anti, meaning against, antithrombins are going to normally prevent overclotting. However, with DIC, the quantity of thrombin far exceeds the amount of antithrombins that we have. And so we lose our inability to effectively slow down the clotting process. And so really, it's this fibrin formation that ends up leading to these multiple clots everywhere throughout the body. So you can probably appreciate that if clotting is happening all throughout the body, that our body is going to be utilizing a high amount of our clotting factors and our platelets. So clotting factors are the factors that contribute to clotting or are necessary for clotting, and platelets are our thrombocytes or our clotting cells. So we're using up so many of these all throughout the body. But if you remember normal anatomy, you know that when there is a clot, then eventually that clot will be broken down. So the fibrin mesh will be broken down by a process called fibrinolysis. And there's going to be now an excessive amount of fibrinolysis occurring, leading now to hemorrhaging. This hemorrhaging leads to widespread ischemia all throughout the body. It means that the organs are not going to be perfused. It can lead to infarction. And if this continues for long enough, then it can lead to multiple organ dysfunction syndrome, talked about next, which can then lead to organ failure and death. So on our very last slide here, we'll talk about multiple organ dysfunction syndrome, and this is the progressive dysfunction of two or more organ systems that result from some sort of uncontrolled inflammatory response. And why is the body experiencing an inflammatory response? Well, somebody's experiencing some degree of severe illness or injury, and an inflammatory response occurs, which can lead to MODS. Now, the organ dysfunction can continue to progress where the organs then fail and the person can die. At one point, this condition was called multiple organ failure syndrome, but people can recover from it, so dysfunction is the more appropriate term. You can think of MODS as being really the end stage of a variety of different injuries that really terminate in this severe systemic, inflammatory, and cell stress response. And it can include apoptosis, where you have all of these cells that are just dying. It's like under this circumstance, they're programmed to die. Now, although sepsis and septic shock, so this is infection, blood infection, and septic shock discussed already. Although sepsis and septic shock are the most common causes of MODS, so that's important for you to know, MODS can be initiated by really any severe injury or disease process where you have this massive systemic inflammatory response. The histologic features of the organs that are involved in multiple organ dysfunction syndrome are considered to be really less well characterized, but it is accepted that it will include the evidence of edema, inflammation, tissue ischemia, necrosis, among other alterations. And remember, this is affecting multiple organs within the body. And with this condition, we're talking about two or more, but you can see at the bottom that 50% will die if two or more organs fail. 80% will die if 3 or more organs fail. And if this lasts for longer than approximately 4 days, 100% of people will die. So definitely a medical emergency. All right, that's the end of this lecture on shock. Thanks for your time.